Dear students, welcome to the second lecture in the topic of inflammation. By the end of this lecture, we should be able to describe in detail the cellular events in acute inflammation, including the steps of leukocyte recruitment and activation, to define phagocytosis and explain its pathogenesis, to list the components and functions of inflammatory exudate. In the previous lecture, together we covered the definition of inflammation, the differences between acute and chronic inflammation, and then we started to understand more about acute inflammation regarding its definition, causes, and also the steps of acute inflammatory response. We agreed that acute inflammation includes two main events, the vascular changes and the cellular events that occur in the setting of inflammation. Regarding the vascular changes, we understood that we have changes in the caliber of the vessel and also the blood flow. And in the same time, we will see also changes in the permeability of the vessel in the form of increase of this permeability to allow the passage of fluid, proteins, and even cells to the surrounding tissues that are the site of the acute inflammatory response. The next step would be the cellular events. The cellular events would include the leukocyte recruitment and the leukocyte activation. And also in the previous lecture together we explored the concepts of leukocyte recruitment and how the leukocytes are going to exit through the vessel wall to go outside into the surrounding tissues. Today we are going to explore this in more details and understand better concepts about the inflammatory exudate. So again, the concepts of leukocyte recruitment include four main steps. The first step is margination of the leukocyte, adhesion to the endothelium, and rolling at the vessel wall. This will happen when the leukocyte or the neutrophil leave the central axis of the blood and then they move toward the wall of the blood vessel to start to roll over the endothelial cells like a snowball. This rolling will be helped by some receptor interaction, and it is going to be very weak adhesion that's going to happen temporarily, and then it is going to be like unattached, and then it will attach again, and then it will leave the cells again in a process of rolling. Then the next step will be firm adhesion, strong adhesion, when the neutrophil is going to be stuck strongly or firmly to the endothelial cells through certain receptors we are going to talk about later. The third step is transmigration of the neutrophils between the endothelial cells. So the cells are going to exit the vessel by gaps or through gaps in the vessel wall between the endothelial cells. So this is called the transmigration. And the last step also is another migration step, but this time migration from the site of the exit from the vessel wall to the site of the inflammatory response, where the chemical mediators are secreted at their highest concentration. So it's like they are called out from the area of their exit to the area of inflammation by chemical mediators. So again, the first step is margination of the leukocytes. As we agreed before, we will see this margination when the white blood cells or the neutrophils specifically leave the central axis or the central column of the blood, if they were wandering around here in the bloodstream, to the periphery of the vessel. Then they are going to roll over the endothelial cells in a process called rolling. After that, during this rolling process, we will see some kind of weak adhesions. These weak adhesions between the leukocytes and endothelial cells are mediated by a family of receptors called selectin family. So selectins are very important family of receptors that we need to remember the name. They are responsible about the weak adhesions. Why we have weak adhesions between the endothelial cells and neutrophils? Because this weak adhesion is a preparatory step before the firm adhesion. So when they are rolling over the endothelial cells, these weak adhesion are going to guarantee that the neutrophils are going to be moving around the periphery of the vessel wall, and they are not going to be moving towards the center of the blood stream again. So we want to keep them towards the periphery of the blood vessel to prepare for their exit, and this will not happen if they don't start to stick to the endothelial cells by the weak adhesions through the selectin family of receptor. Selectins have some types, but we don't need to know the details of these types of different selectins. The next step of the leukocyte recruitment is the firm adhesion to the endothelium, or the strong attachment between the neutrophil and the endothelial cells. This firm adhesion is mediated by another family of receptor called integrins. So, to revise again, the family of receptors responsible about the weak adhesion and the rolling step is the selectin family. Here, the next step, the firm adhesion, is mediated by family of receptor called the integrins. What are the integrins? They are receptors found on the neutrophils or the leukocyte membranes. And the ligands for these receptors or the complementary structures are present on the surface of the endothelial cells. When we have leukocyte activation in the area of the inflammation, these integrins are going to be attached to the ligands or the complementary structures on the endothelial cells, and also under the effect of chemical mediators in the site of inflammation, the endothelial cells are going to express more and more of the ligands for integrin. So this will allow more chances for the firm adhesions between the endothelial cells and the neutrophils. The main chemical mediators that are responsible about this increase of expression of ligands, or increased number of ligands on the endothelial cell surface in the inflammation site, are tumor necrosis factor and interleukin-1. So remember those two factors. They are responsible about many other steps also in inflammation, and here the main role is to express more integrins on the surface of endothelial cells to prepare for the firm adhesion between the endothelial cell and the neutrophil. Now the neutrophil is completely stuck to the endothelial cell, and it's going to, next step, start to go out of the vessel wall to the interstitial tissue. Step number 3 in leukocyte recruitment is transmigration of the leukocytes between the endothelial cells. So the leukocytes will migrate through the vessel wall by being squeezed or squeezing themselves and moving through the gaps that are formed between the endothelial cells. Why we have gaps between the endothelial cells? This happened because of the increased permeability. And we discussed that in the previous lecture. We said that we have endothelial cell contraction, endothelial cell retraction, and also we have endothelial cell injury. And all of those resulted in gaps in the vessel wall. Now those gaps are needed for this step of the exit of the neutrophil between the endothelial cell. This step is called diapedesis. So the migration of the leukocytes through the vessel wall by squeezing themselves between the endothelial cell is called diapedesis. So this is another term to remember. How this is mediated? It is going to be mediated again by some chemical mediators, some chemokines, and also another important factor which is called the PCAM1, or the complete name for this factor is platelet endothelial cell adhesion molecule. So the abbreviation here, the initial of all of these words are PCAM1. So this PCAM1 and other chemokines are going to facilitate this step of the epidesis. After they pass, when they start to move in between the endothelial cell, they will also face another structure that is present in the vessel wall, which is a basement membrane. And this basement membrane is going to be like a barrier. So how they are going to pass this barrier of basement membrane? They are going to secrete some enzymes like collagenases. Collagenases are going to degrade or destroy the basement membrane that is formed of collagen. So collagenase is going to break up or destroy the collagen focally, which means in small areas at the site of exit of the neutrophils, so that they don't have any barriers to go out of the blood vessel. Which cells are going to be seen in the site of acute inflammation? As we agreed before, the predominant cell in acute inflammation is going to be the neutrophil, and they are the main fighters in the acute inflammation. So they predominate especially in the first 6 to 24 hours in acute inflammatory responses. Later on, the numbers of the neutrophils will start to decrease, and another cell is going to come to the area of inflammation in increasing numbers in the following few days. This cell is going to be the macrophage. So we have initially very high numbers of neutrophils in acute inflammation during the first 24 hours, and along the following few days, the rate of the cells or the number of the cells is going to decline, the neutrophils, and other cells are going to replace the neutrophils in the acute inflammatory response, which are the macrophages, and we will understand better about the functions of macrophages and their role in the inflammatory response in the next few slides. The fourth and last step in leukocyte recruitment is the migration of the leukocytes in the interstitial tissues towards the chemical mediators. How this is going to happen? We agreed that the first tissues or cells that met the injurious agent, like the infectious agent or the injury, are going to secrete huge amount of chemical mediators. Those chemical substances are attractive for the neutrophil. So when the neutrophil go out of the vessel wall, they are going to some kind of smell around. Where are the chemical mediators? So they are going to move actively towards the highest concentration of the chemical mediators to start to kill or destroy the injurious agent. So this process is called chemotaxis. So what is chemotaxis? Chemotaxis is the movement of the leukocytes toward the site of infection or injury along chemical gradient. What is the meaning of chemical gradient? It means the change of concentration of chemical substances. The highest concentration is at the site of the injury. Then the concentration is going to be fading around. So it's like exactly if you spray from a perfume. If you spray from a perfume in one side of the room, then if somebody is standing in the other side of the room, they are going to smell it. But if they come closer to you, they will smell the perfume more and more, because when the site that you spray the perfume in is the site of the highest concentration. So this is exactly how the neutrophils or the leukocytes move towards the site of the highest concentration of chemical mediators. This will take us to the next question. What are the major chemotactic factors or chemical substances that are attractive for the leukocytes? We have many chemical factors. We have the bacterial products. So if the bacteria secrete some products in the site of the inflammation, these products themselves are attractive to the leukocytes. They are very irritating to the leukocytes. We have also other cytokines, like for example interleukins, different interleukins like interleukin 8 or other interleukins. We have also other components of the complement system, and we will talk about that in more details in next slides. The main chemotactic complement system components are the C5A and the C3A. These two specifically from the complement system are chemotactic or very chemically attractive to the leukocytes at the site of the injury. The last important chemical mediator that is very chemotactic is the product of arachidonic acid metabolism, like the leukotriene B4. So these chemical factors or substances are some of the long list of the most popular chemotactic substances that are attracting the leukocytes to the site of the injury. Some of them are exogenous. Exogenous means they come from outside the body, like the bacterial products. And some of them are endogenous. Endogenous means that they are secreted from inside the body cells, like the cytokines and the complement components. The next step after leukocyte recruitment is leukocyte activation. After we recruited the leukocytes, they need to be active in order to perform the needed functions and complete the inflammatory response. So how they are going to be active? Again, under effects of many products, like the microbes themselves, the products of the necrotic cells in the area of inflammation that were injured, and also some chemical mediators. All of those can lead to activation of the leukocytes, and this will be resulting in a release or production of some proteins that are going to perform the functions of the leukocytes. So this will take us to the next question. What are the functions of leukocytes in inflammation? The first and the main function is phagocytosis, eating the particles or the bacteria and get rid of them. So this is the first step, phagocytosis. This is a very important process with multiple steps we are going to discuss in the next slide. The next function is to produce substances that will destroy the phagocytosed microbes. So when the leukocyte phagocytose or eat up microbes or harmful substances, they are going to release or produce mediators or substances. These substances are going to destroy whatever they have eaten up, whatever injurious agent is there. These substances include lysosomal enzymes, reactive oxygen and nitrogen species, and others. The other important function is that the leukocytes are going to release mediators, and these mediators are going to promote and aggravate the inflammatory reaction to complete the reaction and to maintain the response. These products include the arachidonic acid metabolites and other cytokines. And we will have a stop with the chemical mediators later on also. So three main functions, we need them to be performed by the leukocytes when they are active. Phagocytosis is number one. Production of destructive substances to the harmful agents, this is number two. Then production of chemical mediators that will maintain the inflammatory response. The first function we mentioned is the phagocytosis. So we need to shed some light on this very important process in acute inflammation. Phagocytosis is the process by which the neutrophils and the macrophages ingest or eat up the bacteria and the foreign particles. And this is a very nice representation of phagocytosis. This is bacteria that was eaten up by a phagocyte, and inside the phagocyte they were digested, and then some residual substances are released from the phagocyte. This is a very good representation, and we are going to explore in details. So in order for this phagocytosis to happen, we have like a very organized steps. The first step in phagocytosis is to recognize this substance that we need to eat or to ingest. How to recognize the foreign substance or the microorganism? The leukocyte will bind or ingest the microorganism or any dead cell or injurious substance through some surface receptors. Those receptors are going to recognize some components of the organisms or some proteins from the host, from our body, that attach it to the organisms. So either the organism itself is going to be recognized by the surface receptor, or it is going to be coated by substance from our body. This coat or jacket that the bacteria or the injurious agent is going to wear is very important for the phagocyte to recognize. The phagocyte will know this coat or this jacket, and it is going to be labeling the injurious agent or the microorganism. So then the phagocyte, when they see this coat, they are going to target this coated substance, and they know that this is very harmful. These coats are going to be called opsinins. So opsinins are substances that are produced from the body that are going to coat the bacteria or the harmful substance in the process called opsonization. So what are the different opsinins that we know? We know famous opsinins like some immunoglobulins like immunoglobulin G and a complement component called C3b. And again, I'm repeating that we're going to discuss more about complement or revise the roles of complement in the inflammation later on. So we have two popular opsinins or coats for the bacteria or foreign bodies. These are the immunoglobulin G and C3b. And again, opsinins are coats that are going to be surrounding those substances to allow the phagocytes to recognize them and target them for phagocytosis. So this is the first step, recognition and attachment to the target. The second step of phagocytosis is engulfment, to take this target inside. When the bacteria are recognized by the phagocytes, the phagocytes are going to extend arms, parts of their cytoplasm, to get these bacteria inside them. This extension of their cytoplasm is called pseudopods. So pseudopods are going to be extended outside, take the bacteria inside, and the bacteria are going to be included in a space or a bubble inside the cytoplasm of the phagocyte called the phagocytic vacuole. So this phagocytic vacuole is going to include the bacteria, and then the next step, the lysosomes that are present in the phagocyte cytoplasm are going to fuse with these phagocytic vacuoles. So the lysosomes are very digestive and destructive enzymes that are present inside certain vacuoles inside the phagocytes. So because they have to be inside vacuoles, or else they are going to eat the phagocyte itself. So they are already protected. These lysozymes in their own vacuoles, surrounded by membranes, are going to target the phagocytic vacuole, which has the bacteria inside. And the membranes are going to fuse together, the membrane of the lysosomes with the membrane of the phagocytic vacuole. When the membranes are fused together, the lysosome will be opened and is going to pour the lysosomal enzymes or the lysozymes inside the phagocytic vacuole to start to destroy the bacteria. This is the second step. So this is the step of the engulfment. When the lysosome fuses with the phagocytic vacuole, this structure is going to be called a phagolysosome. So it's a phagocytic vacuole plus lysosome together. So it is going to be called phagolysosome. The last step is the killing or degradation or destruction of the microorganism by the lysosomal enzymes, or even the reactive oxygen species or the reactive nitrogen species, which target the bacteria and destroy them. And then these microorganisms are going to be completely degraded, and any residual is going to be released outside the phagocyte. Now the phagocyte completed their action and they got rid of the injurious agent. So whether this phagocyte or the cell that underwent the phagocytosis is a neutrophil or a macrophage, they now perform the function very well. And after they destroy most of the organisms or the injurious agents in the site of the inflammation will subside and will be resolved, because now there is no more reason for more inflammatory response if we got rid of all the bacteria. So again, to sum up the process of phagocytosis, here we have a phagocyte, which could be a neutrophil or a macrophage. Then we have here a microbe or any other foreign particle. The phagocyte will extend pseudopods or extensions of the cytoplasm to engulf the microbe after it is coated by an opsinin. That will make the phagocyte recognize the microbe. Then this will be forming a phagosome or a phagocytic vacuole. Afterwards, the lysosome, which includes the lysosomal enzymes inside its membrane, will fuse with the phagocytic vacuole or the phagosome, and together they will form the phagolysosome. Here, the digestive enzymes will meet the bacteria and they will destroy the bacteria, and any residual products will be released out of the macrophage or the neutrophil. So the steps can be divided into three major steps: recognition and attachment, the process of the engulfment, and then killing or destruction of the bacteria. Before I leave this section, I'd like to highlight some facts about the complement system, because we mentioned every now and then some complement components. This part is not included in our curriculum, but it's just a revision of what you have learned about complement in the immune system. So the complement is a part of the immune system that helps clearing microbes and any damage resulting from an organism or an attack that will result in inflammation. So this system is comprised of like proteins that are mainly synthesized by the liver, and they circulate inactively in the circulation. And at some point, if they are activated, they will be resulting in a cascade of events. This will lead finally to release some important cytokines or perform certain functions that will help in three main functions. The first main function is helping the phagocytosis by opsonization. And the second main function is chemotaxis, or attraction of the neutrophils and macrophages in the process of inflammation. Then there are other functions, especially attacking the membranes of the bacteria. So the main component of the complement that will help as an opsonin to coat bacteria to facilitate the process of phagocytosis is the complement 3B. The major two chemotactic complement components that are going to work as attractive substances for the neutrophils at the site of inflammation are complement 3A and complement 5A. So I hope with this slight revision of the complement system, we will not forget the different component of the complements and their important roles in the inflammatory reaction. Now we completed all the steps of acute inflammatory response. We understood the different vascular changes, and we explored the cellular events in the form of leukocyte recruitment and leukocyte activation. Now we are ready to understand more details about the inflammatory exudate. So we have to follow this nice illustrative diagram. This is a normal blood vessel lined by endothelial cells, and they are resting on a basement membrane. and inside we have the blood flowing. Inside the blood we have some plasma proteins. And as we previously spoke about the forces that control the fluid movement across the blood vessel wall, we have a hydrostatic pressure that is exerted by the fluid inside, and in osmotic pressure that is exerted by or present because of the plasma proteins inside the blood. So the plasma osmotic pressure is dragging fluid inside the vessel wall, and the hydrostatic pressure is pushing to let the fluid leak outside the vessel. And those forces are in a balanced state. In some conditions, we have increased hydrostatic pressure inside the vessel. So we have more fluid inside, and this will push the fluid to go outside the vessel in increased amount. These conditions are caused by especially cases of venous obstruction. If there is venous obstruction, like in cases of heart failure or any other mechanical obstruction of the veins, the blood will accumulate in the vessels backward, and this increased blood will have more hydrostatic pressure, and this will lead to losing more fluid outside. But because the endothelial cells are very tightly adherent to each other, this will not allow movement of anything else other than fluid only. And in this case, this fluid will be called transudate. So this is a case where we have increased hydrostatic pressure only. In some other cases, like in our inflammatory conditions, we have also some increase of the hydrostatic pressure because of the vasodilation and increase the blood flow. But in the same time, we have increased capillary permeability. So this increase of the hydrostatic pressure is leading to more fluid outside, and also because of the gaps in between the endothelial cells, not only the fluid is getting out, but also the proteins and also the cells. So this cocktail of fluid, proteins, and cells getting outside the vessel in cases of inflammation is called exudate. And when we have more proteins out, the osmotic pressure of the plasma is reduced, and this is also going to help or facilitate passing out more fluid outside the vessel, because the fluid will always move towards the place where that has more proteins. So now proteins are higher in the interstitial tissue, so they will drag the fluid also additionally with the increase of the hydrostatic pressure. So again, this cocktail is called the inflammatory exudate. So we have many cases or like diseases or conditions that will lead to a leakage of fluid outside the vessels. Sometimes this leakage is only fluid because of increased pressure inside the vessel, and it will be called transudate. But in our case here, that is the most important concept to understand in this slide, is how inflammatory exudate is formed and what it is composed of. So it is formed because of mixture of factors: increased hydrostatic pressure, decreased osmotic pressure, and increased capillary permeability. So again, the pathogenesis to form the inflammatory exudate, we have increased vascular permeability, arteriolar vasodilatation, and increased osmotic pressure in the interstitial tissue because of increased plasma proteins in the interstitial tissue. And in the same time, decreased osmotic pressure inside the blood vessel because of loss of the proteins from inside the blood vessel. These are the three main factors that led to formation of the inflammatory exudate. What are the components of the exudate? Plasma or fluid rich in proteins, especially fibrinogen. So this is why it can clot on standing. And the protein content of this plasma is above 4 grams%. Its specific gravity is above 1018, which is a high specific gravity. And this is opposite to the transudate that we mentioned before. It is very protein poor. Then we have other cells that passed out also the vessel wall, the neutrophils, and the macrophages. So these are the main components of the inflammatory exudate. This will take us to the next section. What are the functions of inflammatory exudate? Why we need this cocktail? How it's going to help in the inflammatory response? The first function is this exudate will dilute any bacterial toxins. So if there is any toxin secreted by the bacteria, if we have some fluid around this toxin, the concentration of the toxin will be less, and this will help to minimize the damage of the toxin. The second function of the inflammatory exudate is bringing out antibodies along the plasma proteins to the area of inflammation. These antibodies include bacteriolysins, agglutinins, and opsinins that are going to destroy or fix or coat the bacteria. So all of these proteins or antibodies are coming out with the inflammatory exudate, and they are all going to work some way or another on the bacteria and lead to its destruction or help its destruction or phagocytosis by coating or opsonization, as we mentioned before, immunoglobulin G, that is one of the popular opsinins. The third function of the inflammatory exudate that it contains amounts of fibrinogen. When fibrinogen gets out the blood vessel, it will change with a reaction into fibrin. Fibrin will be like threads. It will form a network like the spider web. This network in the area of the inflammation is very important. It will support the leukocytes during their movement from the vessel wall to the site of the inflammation during the chemotaxis process, or their migration, in another word. So when they migrate or move in the tissues, they need support, they need a scaffold. So it's like exactly a spider web that the neutrophils will use to move around in the tissues. So this is very important function of the fibrin. The other function of the fibrin that it is going to localize or surround the area of inflammation and prevent its spread or extension in the neighboring healthy tissues. So it's going to like imprison the inflammatory cells and the reaction inside certain areas without further spread. So these are two functions of fibrin that is coming from the fibrinogen that is coming with the inflammatory exudate. The last but not least, this exudate, it's containing neutrophils and macrophages also, and those cells are going to be activated, and with activation they are going to destroy the organism or the injurious agent. And after they are killed, the organism, also this will affect the neutrophil, and neutrophil will be very exhausted and it will be killed eventually also. So it will change into another cell called pus cell. This pus cell is going to produce some enzymes to make the tissues around the inflammatory area necrotic or dead, and prepare the area for repair. This is a complicated process that we are going to highlight furtherly in the following lectures. But again, to repeat, so the neutrophils are coming with the inflammatory exudate. They have main function, they need to kill the bacteria by different mechanisms. The most important is phagocytosis. After that, they are going to be killed themselves, and they are going to be converted into other cells, which are the pus cells. And we are going to talk about that later. These pus cells are going to secrete more powerful digestive enzymes. They are also going to destroy some tissues in the area of inflammation and make them dead or necrotic. And this is important step. Why? Because this area of inflammation is so much damaged. We need to clean the area so that we can repair it, or we can lay down some tissues to fill in this destroyed, damaged tissue. So this repair needs preparation. To prepare for repair or healing or cleaning, we need to first liquefy or make the fluid fade away, the necrotic or damaged tissue, make it go away by lysis, by powerful enzymes. And then we can start the process of repair, as we are going to explore later. Now we can go through some activities to revise what we have learned in this lecture. In this first activity, we can try to connect the definitions to their terminology. So here we have, to the left side, we have the terms diapedesis, phagocytosis, chemotaxis. On the right side, we have the definitions. First one, the movement of leukocytes towards sites of infection or injury along a chemical gradient. Or we have migration of leukocytes through the vessel wall by squeezing between the cells at intercellular junction. And the last one is a process by which neutrophils and macrophages ingest bacteria and foreign particles. So let's start with diapedesis. Which one is a good definition of diapedesis? Yes, it is the migration of leukocytes between the endothelial cells through the gaps by squeezing themselves. The next term is phagocytosis. From the remaining definition, which one is the good definition for phagocytosis? Yes, this is the process by which the neutrophils and macrophages ingest bacteria and foreign particles, and as we agreed, it consists of 3 steps: recognition and attachment, engulfment, and killing of the microorganism and its destruction. The last one would be the chemotaxis, would be the movement of leukocytes towards the site of infection or injury along chemical gradient, and this is from the name. Chemotaxis happens because of movement along chemical gradient, and we mentioned many chemotactic factors. In this next activity, we have 4 sets of factors or substances here to our right side of the slide, and we have some functions here on our left side of the slide. So we are going together to read the function and choose from the list of factors or substances the most suitable one for this function. So the first function we have is forming a network on which the leukocytes move in the direction of the organism, and it also localizes the infection at the site of inflammation. So from this list that we have here, we have pairs like C3b and immunoglobulin G, we have C3a and C5a, we have fibrinogen and its product fibrin, and then we have tumor necrosis factor and interleukin 1. Till now, till this lecture finished, what is the pair or what are the factors that can do function number 1? Yes, it's fibrinogen and fibrin. So fibrinogen is the precursor, and then fibrin is the product that is going to do the function. Fibrinogen is one of the components of the inflammatory exudate. One of the common chemotactic factors are complement components like C3a and C5a. These are popular chemotactic factors, and we explored their locations in the complement cascade. Opsinins are substances that are going to coat the microorganisms to prepare them for phagocytosis. Which of the repairing pairs can be a factor working as opsinin? Yes, it is T3b, complement 3b, and immunoglobulin G. They are popular opsinins. And this leaves us with the function number 4, increased expression of integrin ligands on the endothelial cells. What are integrins first? Integrins are the receptors responsible of firm adhesions of leukocytes to the endothelial cells. So the tumor necrosis factor and interleukin 1 are going to function as in this function, increase expression of integrin ligands, and they are going to have many other functions along the inflammation that we are going to discuss later also. Thank you so much for listening. By that, we reach the end of this lecture, and we are going to move on to the next lecture, number 3 in inflammation.